It's April Fool's Day 2017. For those who didn't know, thanks for tuning into BrainWaves. I'm Jim Siegler. This week we're not going to cover a case or review a single topic like we usually do. For this episode, we're going to cover a series of topics to see just if you can be fooled as a neurologist. While some of these topics don't seem like they'd fool you, like they'd be pretty straightforward, yeah Jim, obviously a patient can still have epilepsy if the EEG is normal. It's my goal for this episode to make you doubt yourself and everything you've ever been taught. Part 1. Killer Headache. The question is, if the head CT is negative for subarachnoid hemorrhage, do I need the LP? What do you think? Yes or no? Take a minute to decide. And hopefully, after this explanation, I'll have either convinced you to doubt whatever your original decision was, or validated that decision. At least, when I'm on call, I'm always doubting myself when confronted with these kinds of cases. First of all, when should you expect an aneurysmal subarachnoid hemorrhage? Like Dr. Kankanian said way back in episode 8, aneurysmal ruptures are like an explosion, and they create a thunderclap headache. There is a rapid rise in intracranial pressure as the highly pressurized arterial blood enters the subarachnoid space and irritates the meninges. Often there's nausea and vomiting, and sometimes cranial nerve palsies are observed. And even in severe cases, there could be loss of consciousness or coma, if the patient survives. Without trying to give medical advice here, thunderclap headache or worst headache of life in an adult warrants emergent neuroimaging. The question posed here, if the head CT is negative, can the patient still have a subarachnoid hemorrhage? Well, as you might have expected, since this episode is all about fooling you, technically, yes, there can still be a subarachnoid hemorrhage with a normal head CT. I think that two of the biggest contributors to a normal appearing head CT in aneurysmal subarachnoid hemorrhage are the generation of CT scanner and the timing of the scan. Obviously, a lower quality CT scanner may not give you sufficient definition to identify a subarachnoid hemorrhage. The newer third-generation CT scanners available at most hospitals in the US nowadays no longer really have this problem, so I think we can rule out this factor in most cases. The second contributor to a normal head CT is the timing of the hemorrhage. Sure, a subarachnoid bleed may be small, and you can imagine that the kinds associated with perimesencephalic subarachnoid hemorrhages or vertebral artery dissections may be small enough or caudal enough to go unnoticed on a routine head CT. But if you have an intracranial aneurysmal subarachnoid hemorrhage and you get the scan within a few hours of onset, there's almost no way you should miss the blood. Let's say, for the sake of argument, the patient got the lumbar puncture. One problem I've come across a few times is the patient with a thunderclap headache, a normal head CT, and a large number of red blood cells in the CSF. Now, we already covered how to adjust for red blood cells by the tube number in episode 49 with Dr. Mike Rubenstein on CSF analysis. But unfortunately, there's no good way to rule out a traumatic lumbar puncture. It would be great, of course, if you saw the number of red blood cells drop from 20,000 to 0 between tubes 1 and 4, but that almost never happens. More often, you see a 17,000 to 9,000 drop. What the f*** am I supposed to do with that? And then you end up admitting the patient, getting serial CT angiograms, exposing the patient to contrast and radiation, treating them with nimodipine, then they get a DVT because they're bedbound and you're withholding prophylactic heparin, and they decondition from being bedbound, and all the while you're kicking yourself because you know this really was just a migraine. Clinically, I think it boils down to a judgment call. The bottom line is, while the answer on the test question is always going to be, get the lumbar puncture after a normal head CT, sometimes there's greater equipoise in discharging the patient with sound advice and close neurologic follow-up. Or if you have a high suspicion that the CT quality was poor or the scan was delayed, then it's worth getting that LP. Part 2. I just can't fight this feeling any longer. The question is, if a patient sounds like he or she has a peripheral neuropathy, can the EMG and nerve conduction study be normal? Yep, another normal study to confuse you here. And you were convinced that your patient has a peripheral neuropathy. Like a head CT and subarachnoid hemorrhage, the timing of the study can dramatically impact the results. A nerve conduction study can be totally normal within the first 4 to 6 days of nerve injury, even if the nerve is completely transected. That's why it takes a week or so before we see nerve conduction changes in acute peripheral nerve injury patterns like the Guillain-Barré syndrome. After that 4 to 6 day grace period, using the example of transection, then you'll start to see features of Wallerian degeneration, things like a drop in the sensory nerve action potential or SNAP. And moving on to a radiculopathy, the SNAP will be normal. This is a critical feature of the nerve conduction study every neurologist knows. Because the dorsal root ganglion exists outside of the spinal cord, neural foraminal stenosis will injure the proximal axon of the dorsal root ganglion, leaving the distal axon completely preserved. And you can still have the sensory changes in a dermatomal distribution even with this normal SNAP response. That's because the sensory signal is reaching the dorsal root ganglion, but it's not getting through to the spinal cord through that foraminal narrowing. The only way to confirm it is a radiculopathy is to test the motor nerves, whose cell bodies line the anterior horn of the spinal column, and you'll find that those nerves aren't conducting well. But now let's say that the patient has a sensory disturbance. It's lasted longer than a week, and the nerve conduction study is still normal. How is that possible? Well, now we have to consider the limitations of your testing. Either you're not doing a good enough physical exam, shame on you, or the nerve conduction study is failing to capture a sensory disturbance. For the sake of the podcast, let's just say you rock. You did everything right and your exam is flawless. The patient definitely has impaired temperature discrimination in all 5 fingers of her right hand, and you're thinking that she's faking it. But the nerve conduction study is normal. That being said, if all the patient is complained of is pain or temperature disturbance, these signals are carried by small myelinated A, delta, or B fibers and unmyelinated C fibers. And these fibers are not measured during a routine nerve conduction study. You can only pick up the large myelinated somatic cutaneous afferent fibers using the nerve conduction study. So what do? Well, in general, there's a lot of overlap between these fibers that carry pain and temperature information and autonomic afferents and efferents. Both fiber types, carrying pain and autonomic data, are small diameter unmyelinated C fibers with really slow conduction velocities, something like 1 to 2 meters per second slow. The reason this is clinically relevant is that it would be extremely unusual to have a pure neuropathy that only affects the C fibers, which convey pain and temperature information. But I guess it does happen, and some might say that fibromyalgia is one of the diagnoses we might consider in that spectrum of diseases. More often, the patient will have a small fiber neuropathy, affecting both the nociceptive C fibers and the autonomic C fibers. So testing a patient for autonomic dysfunction may be more telling here. I usually evaluate for orthostasis using a formal tilt table test and send these patients to GI for a gastric emptying study. But you can also evaluate for pseudomotor dysfunction with a thermoregulatory sweat test. To do this, you will apply alizarin red or iodine cornstarch to the skin in a humidity-controlled chamber. As the temperature in the chamber rises, the patient should sweat, turning the indicator dyes to a different color, yellow to red for alizarin or brown to purple with iodine. Another way to assess autonomic dysfunction would be to measure a post-void residual volume of the bladder using ultrasound, or by performing more advanced urodynamic studies. If your suspicion of a small fiber neuropathy is confirmed, then you can proceed with working the patient up based on that differential diagnosis. Diabetes is the most common cause of a small fiber neuropathy in the US, and you should eventually see large fiber dysfunction on nerve conduction studies as the disease progresses. Other diagnoses to consider include chronic alcohol use, some medications, especially the antivirals DDI and DDC, amyloidosis, often associated with the transthyretin gene mutation, B6 deficiency or intoxication, Sjogren's syndrome, anti-HU paraneoplastic syndrome, and rare heritable forms such as Fabry's and Tangier disease. But if your suspicion of a small fiber neuropathy is not confirmed in the ancillary autonomic testing, you're left either with a very unusual condition, or your patient has an inorganic cause to explain his or her symptoms. The last thing you can do here, and the gold standard for diagnosis of a small fiber neuropathy, is to perform a skin biopsy. Part 3. Twist and shout. Question. If the EEG is normal, can the patient still have epilepsy? By this, I don't mean you get a routine EEG on a patient suspected of having epilepsy, and the EEG looks fine. No. And I'm not trying to drown you in facts like how 2/3 of EEGs in patients with epilepsy may have a normal 21-minute recording. You know that the interictal recording can be normal, and it won't exclude epilepsy. The reason we obtain an EEG in patients suspected of epilepsy is to identify potentially epileptogenic regions, something like temporal slowing, or focal epileptiform discharges, that kind of thing. Now going back to the question, if the EEG was normal on a patient actively experiencing a clinical event, meaning a behavior that clinically resembles a seizure, does that exclude the diagnosis of epilepsy? 2 years ago, I was caring for a young woman in an epilepsy monitoring unit. She was healthy, in her 20s, brought in for a differential diagnosis of nocturnal thrashing. Every few days, her roommate would find her swinging her arms violently in bed, thrusting her hips, shaking her head from side to side. The patient denies recollection of these events, and they seem to have originated out of wakefulness. So we monitored her on the EEG. When it finally happened, this nocturnal thrashing event, it was actually kind of terrifying. I was called into the room to evaluate her as her body hurled itself back and forth between the padded rails. Her mother was at the bedside. She watched vigilantly, eyes welling up with tears as I looked back and forth between her daughter and the cryptic EEG tracing. Scrolling back through the pages, the event had clearly occurred out of wakefulness and had become completely distorted by muscle artifact. Between her head turns and hip thrusts, I could see normal wakefulness architecture in the EEG. There were no lateralizing abnormalities, no slowing, no epileptiform discharges. I called the epilepsy fellow just to confirm I wasn't missing a real seizure event, and she confirmed this event was non-epileptic. The mother's eyes remained glued to me as I stood by the patient, violently shaking in bed, screaming, "Help me! Help me!" It wasn't long before the mother demanded that I do something to make it stop. This wasn't an ideal circumstance for me to bring up the difference between seizure and non-seizure. You just can't do that. You can't reason with a mom whose only instinct is to protect her child. Reluctantly, I pushed 2 milligrams of intravenous lorazepam, and in doing so, treated both the mother and the daughter. "It's going to be okay," I said, and the patient calmed. A wave of lethargy slowly took hold, and the strong grip she had on her mother's hand began to soften. There's a simple law of mathematics, that if x equals y, then x always equals y, the law of equality. Although this is an elementary mathematical principle, it holds true among epileptologists as well. If a clinical event is no seizure on EEG, then we make a leap of faith that the same clinical event is no seizure when off EEG. This patient who experienced these unusual nocturnal events of whole body shaking, head twisting, and shouting did not have a seizure on EEG at the time of this clinical event. Therefore, we've assumed that whenever she experiences the same event at home and off the EEG, it's still not a seizure. All those nights when she was found by her roommate thrashing in bed, shouting, in distress, we assumed that those were not actually seizures. But is that a fair assumption? Obviously not, or I wouldn't have asked you. First of all, this patient could have had an electrographic seizure at the time of a prior clinical event, and we just didn't have her monitored on EEG. Our decision-making is limited by the available data we have, and we're pretty confident that x will always equal y. A non-epileptic event that we see on EEG has always been and will always be non-epileptic. And you can reassure yourself that this is the case because many times non-epileptic events will fail to improve with anti-epileptic drugs, and they will often improve with psychiatric intervention. Second of all, there's a huge overlap between psychogenic non-epileptic events, PNEE, and epilepsy. As many as 30% of patients with epilepsy have non-epileptic events, just like the event I saw in the young 20-year-old girl. So she could definitely still have epilepsy. And it turns out, as we continued to monitor her on the EEG, she experienced complex partial seizures throughout the day, which many of her friends hadn't noticed because she had spent so much time studying in college. Third of all, the scalp EEG can be totally normal in a patient who's experiencing an electrographic seizure. Technically, you need 6 square centimeters of abnormally firing cortical tissue before you can detect a seizure on a routine scalp EEG. Intracranial electrodes are far better at detecting abnormal discharges or seizures, and you'll often see patients with depth electrodes or cortical grids who are being monitored in the hospital to really localize a seizure origin. These are placed for surgical planning. Also, the standard scalp EEG setup dedicates a large number of superficial electrodes to the temporal lobes, which are thought to be most epileptogenic, and very few electrodes to the frontal lobes. So some have argued that you can miss a frontal lobe seizure on a routine scalp recording, even during a clinical event, unless you perform that dedicated study. I think the takeaway message here is to recognize the limitations of your diagnostic techniques. Trust your exam and your instinct when evaluating these more unusual patients. Just because your test may be normal, don't be fooled by the patient's legitimate symptoms. And we'll call that a wrap this week for BrainWaves. Happy April Fool's Day, everybody. I'm Jim Siegler. Talk to you next time.
Thanks for listening to BrainWaves today. If you like what you just heard, you can find more related material on the web at brainwaves.me or find us on Twitter at brainwavesaudio. Feel free to contact us at bweditorialboard@gmail.com. Be sure to check out our iTunes archive for older episodes. This episode was produced by Jim Siegler. Music by Justin Warren. Steve Combs. I'm Erica Mejia. Join us next time for another edition of BrainWaves.